Hello everyone and welcome. I'm Professor Shaibu Oricha Bello, and in this session we're going to work through the antifungal agents together. By the end of this video you'll be able to name the major drug classes, the polyenes, the azoles, the echinocandins, flucytosine, and the allylamines, and just as importantly, you'll walk away with a set of memory aids that make these drugs stick both for your exams and out on the wards. So grab a pen and let's get started. Before we touch a single drug, let's understand why antifungals are so hard to develop. Here's the core problem. Fungi are eukaryotes just like us. They share a huge amount of cellular machinery with our own cells, so a drug that kills the fungus can very easily harm the patient too. That's the selective toxicity problem. Our safe targets are the few structures fungi have that we don't, mainly ergosterol in the membrane and the beta-glucan cell wall. Keep those numbers in mind. Over 1.5 million deaths a year from invasive fungal infections. Just 4 core drug classes doing most of the clinical work, and one shared weak spot, ergosterol, that we exploit again and again. Now here's a trick that will save you in the exam hall. You can often read a drug's class straight off its name. Just from the suffix, anything ending in -azole is an azole, fluconazole, itraconazole, voriconazole. Anything ending in -fungin is an echinocandin, caspofungin, microfungin, and idulafungin. And the polyenes carry that -sin or -tin ending amphotericin B and nystatin. A few stand-alone agents break the pattern: flucytosine, terbinafine, and griseofovin, and we'll handle those separately. Our mnemonic here is suffixes sort the shelf. Spot the ending first, and the class and even the rough mechanism follows. Every antifungal we discuss hits one of just 4 targets, so let's map them out now. Target 1 is the cell membrane, specifically ergosterol polyenes bind it to punch pores, while azoles and allylamines block its synthesis. Target 2 is the cell wall, the beta 1003 glucan. That's where the echinocandins work, inhibiting glucan synthase and causing the cell to burst. Target 3 is nucleic acid. Flucytosine turns into 5U and shuts down DNA synthesis. And target 4 is the mitotic spindle, griseofovin jams, the microtubules in dermatophytes. 4 targets. Hold that framework in your head and everything else hangs off it. Let's start with the polyenes, and the big one is amphotericin B. Its mechanism is beautifully direct. It binds ergosterol in the fungal membrane and forms transmembrane pores. Ions leak out and the cell dies, so it's fungicidal. This is our broadest spectrum antifungal, the last line for severe invasive mycosis and for mucormycosis. But that power comes at a price, which is why the mnemonic is unputterable. The infusion reactions and kidney toxicity make it genuinely hard to tolerate. Its cousin nystatin is far too toxic to give intravenously, so we keep it topical: oral thrush, skin, and vaginal candida. Amphotericin B deserves a whole slide on toxicity because this is heavily tested. The dose-limiting problem is nephrotoxicity, so hydrate your patient and monitor creatinine. During the infusion itself you get fever, rigors, and chills. Remember it as shake and bake, so premedicate and give it slowly. It also wastes electrolytes, dropping potassium and magnesium, and it causes anemia by lowering erythropoietin. Rapid infusion can trigger hypotension and arrhythmia, and you'll often see phlebitis at the drip site. One key point, nephrotoxicity hits up to half of patients on the standard deoxycholate form, but the liposomal formulation is far gentler on the kidneys. On to the azoles, the workhorses of antifungal therapy. Their mechanism is to inhibit lanosterol 14 alpha demethylase. That's the CYP51 enzyme that converts lanosterol into ergosterol. Block it, and you get defective, leaky membrane and arrested growth. Now split them into two families. The imidazoles have two nitrogens in the ring, clotrimazole, miconazole, ketoconazole. They're older, mostly topical, and carry more side effects. The triazoles have three nitrogens, fluconazole, itraconazole, voriconazole, posaconazole. These are your systemic work order, safer and with better pharmacokinetics. Let's give each major triazole a one-line personality so you never mix them up. Fluconazole, flu can do candida, great for most candida and for cryptococcal meningitis, but it can't handle C. cruzi or the molds. Voriconazole, vori to aspergillus, the drug of choice for invasive aspergillosis. Just watch for those visual disturbances patients describe. Posaconazole, posa plus mucor, the broadest azole. Our go-to when the mucorales are in play. And itraconazole, itra inconsistent because absorption from the capsules is erratic, so we monitor drug levels. Here's where azoles catch people out drug interactions. The headline is CYP 450 inhibition, azole zap P450. They block the fungal P450 that makes ergosterol. Yes, but they also inhibit the human P450s that clear other drugs, so levels of warfarin, statins, and many others climb dangerously. Beyond that, watch for hepatotoxicity, so monitor liver function. Several azoles prolong the QT interval. Ketoconazole in particular blocks steroid synthesis, dropping testosterone and causing gynecomastia and reduced libido. And they're teratogenic, so avoid them in pregnancy. The echinocandins are elegant because they hit a target we simply don't have, the cell wall. They inhibit beta 1,3 glucan synthase. The wall loses its strength and the fungus bursts by osmotic lysis. These are the dash fungins, caspofungin, mycofungin, and nidulafungin, given intravenously. First line for invasive candida, including azole-resistant strains, and generally very well tolerated. But know their blind spots. Our mnemonic A, no crypto, no mucor reminds you they don't cover cryptococcus or the mucorales, and they penetrate the C, S, and the I poorly. Flucytosine or 5FC is our antimetabolite. Follow the pathway, it enters the fungal cell. Cytosine deaminase converts it to 5-fluorouracil, and that 5-FU block stimulates synthase, shutting down DNA and RNA synthesis. Clinically, its home is cryptococcal meningitis, but never use it alone. Resistance develops fast, so we always pair it with amphotericin B for synergy. And because it becomes 5-FU, its toxicity mirrors chemotherapy, bone marrow suppression with a narrow therapeutic window, so monitor those blood counts. For the superficial infections, skin, hair, and nails, 2 agents matter. Terbinafine is an allylamine. It inhibits squalene epoxidase, so toxic squalene builds up inside the fungus. It's our choice for onychomycosis and dermatophyte infections, but watch for hepatotoxicity, GI upset, and that classic taste disturbance. Griseofulvin works differently. It disrupts microtubules to arrest fungal mitosis, and it deposits into keratin. Use it for tinea and ringworm of the skin, hair, and nails. And remember, it's a teratogen, P450 inducer, and it commonly causes headache. Let's consolidate the toxicities, because examiners love to test the signature association for each drug. Amphotericin B, nephrotoxicity, plus the shake and bake fever and chills. Azoles CYP450 interactions, hepatotoxicity. And drop testosterone with ketoconazole. Echinocandins, the best tolerated, just mild GI upset and flushing. Fusitosin, bone marrow suppression, because it acts like 5-FU. Terbinafine, hepatotoxicity and taste disturbance. And griseofulvin teratogen and P450 inducer. If you can recite this table cold, you're in great shape for the exam. Before we wrap up, a quick look at the horizon. Resistance is rising. Candida auris and azole-resistant Aspergillus fumigatus are spreading through hospitals, driven by target enzyme mutations, efflux pump overexpression, biofilms, and reduced drug uptake. But the pipeline is promising. Rezafungin is a long-acting echinocandin you can give once weekly. Ibrexafungerp is an oral glucan synthase inhibitor. Olorofim blocks fungal pyrimidine synthesis through a brand new mechanism. And fosmanogepix hits a novel target called GUT1 with a very broad spectrum. Exciting times ahead in this field. Let's tie it all together in 5 lines. 1. The name reveals the class -azole, -fungin, and the polyene -syn or -tin endings. 2. There are 4 targets: the membrane, the wall, nucleic acid, and the mitotic spindle. 3. Amphotericin is broad but brutal shake and bake plus nephrotoxicity, with liposomal being the kinder option. 4. Azoles, ZAP-P4, 5, broad and oral, but you pay with interactions, liver toxicity and QT prolongation. And 5. Match the bug vori to Aspergillus, posa to mucor, and flucitosine plus amphotericin for Cryptococcus. Thank you so much for watching. If this helped, do share it with your study group, and I'll see you in the next lecture.